wasting any more time, I'd like to hand first of all on to Marcos, to Eric, who's going to kick us off. So over to you, Eric.
Thank you very much, Simon. I will share my screen just to see the slide. I cannot. Simon, can you authorize me to share my screen?
Sure.
So in between, I want to thank the Resilience Engineering Association, Ivan Herrera, the president of the association, to invite me to contribute to this seminar, to this webinar that we have all experienced during this COVID-19 crisis management. I'm a researcher at MINPARITech in the Center of Research on Risk and Crisis. And my speak will be about borders, transboundary crisis, and is done in the context of a joint project, French-German joint project that involve the Karlsruhe Institute of Technology, the University of Wuppertal, the Paris-Dauphine University, and MINPARITech. And this project is studying the specificity of borderland resilience. Okay, so we are actually experiencing a transboundary crisis. A transboundary crisis affects at the same time different countries, and actually, which are quite a global shock, that quite all the countries are affected at the same time by the same hazard. And the specificities of this transboundary crisis is to generate coordination problem at the interface between organizations, states, supranational, and that create people necessary to cope, to respond to situations that for which they are not prepared. The probability of this type of crisis is increasing due to globalization, the growing interdependence of critical infrastructure, and past events such as economical crises and tendency such as deregulation, climate change, numerization. The exposition of territory is also increasing due to centralization and concentration of critical infrastructure, of economic activity and assets, and for the heightened mobility of goods, capital, people, and information. And the resilience to transboundary crises is a challenging question because the presence of one or several borders challenge the capacity to map and model transboundary hazards and to define task and capacity to prevent, mitigate, and to respond and recovery to such hazards. Borders which play a role are firstly line separating two systems, organizations, countries, administrative division. This line could be a natural borders, mountain, river, lake, etc., or artificial, stone tablets, wall, wire entanglements, or a simple geometrical line on a map. But more than a line, a border creates the emergence of a liminal zone, which is both and or either nor the different systems. For each part of the border, create an area with a specific culture, with specific behavior, which are the results of the adaptive capacity of individual organizations that learn to live together, just separate by a border, and building coordination, cooperation activities involving the different part of the border. The border is also in motions. Borders are dynamic. The border move itself, geomorphology of natural borders, or are moved by other political and military conflicts, economical reforms. And borders divides flow of circulations with including and excluding parts of the flow. So the borders, it's concentrate flow dynamics with allowing some flow to go from one part to the other, or exclude some flow that generate new flow, new dynamics of people, goods, or information. And for European Union perspective, and for most of the citizens, the notion of borders was, since Maastricht Treaty, since Schengen, we forgot what was a border. We doesn't experience too much the impact of a border on our life. And the COVID-19 records the existence of borders. So we can model, we can represent the COVID-19 crisis response with considering 5 phases. From an initial alert, a phase of slow down the introduction of the virus into a territory, a phase of slowing the spread of the virus on the territory, a phase of mitigating the effects of the epidemic wave, and a phase of back to a routine, a normal situations. And associated to each phase, there is tasks that are performed and that require different actions. And most of the tasks are affected by the presence and the dynamic of borders. When starting the first phase, the initial alert, when information uncertain suggests that somewhere in the world a new influenza virus with pandemic potential emerge, states have to start different action, different tasks, such as asking for meeting at the supranational level, to assess the quality of the informations, to start survey, to start organizational internal watch and epidemiological surveillance of the area, but also to start communicating information related to people that going or not from the area, and start thinking to the protection of citizens. And the COVID-19 experience show that the variability of the cooperation at the cross-border level, from no cooperation, communication, consultation, coordination, or full cooperation, but also the general and the crisis management specific cultural differences have an impact on the delays of the task, of information quality, and on availability of resources and expertise. So this communication, and in our case with China, and from people which are abroad or near of this area, the communication or the difficulty with cooperation creates some delays of the initial alert, and create some delays on the understanding that pandemic potential was possible. And during the other phase, where states start concretely accomplishing tasks related to other countries, but also outside the country, borders starts to close. So the viability of the state of the border starts creating issue, firstly with transport capacity, but also hotel capacity, foreigner stigmatizations, and competition between states. So during these phases, traveling, finding an hotel, going back to home start to be very difficult, quite impossible. So all these tasks demonstrate that the preventing and the mitigating actions using borders starts create people difficulties and require resilience capacities to perform some routine tasks that transform in very difficult. COVID-19 also reveals the uniqueness of borderland. So these areas at the in between different countries. The European Union policy on internal borders since the emergence of Europe is a trade-off between the utopia of border disappearance and the health of state citizens. So on the one hand, the free movement of European citizens inside the Schengen area was the dynamic of Europe since the initial treaties until the last treaties. But the health protections, remain at the responsibility of states. And related to this responsibility, they have the possibility to close the border or not, to confine population or not, to require the wearing of a mask to their population or not systematically. And this trade-off between free movement and health management creates in time of a pandemic the emergence of new phenomena and difficulties at the border. And if we take on March 16, the borders between France and Germany closed. And suddenly, where we were working together, and the symbol could be the garden of the two banks between Strasbourg and Gill, where French and German people used to take leisure time together. Suddenly, on the bridge, we were fires and policemen. Tram and bus routes were changed. Citizens must follow both French and German rules. People need 4 different attestations to go working. Teleworking, that start to be a new routine during this phase, challenge social security regimes and rules related to French and German difference rules related to social security regimes. And we observe the recurrence of national thinking, despite the fact that we have a very good collaboration between hospitals. So in order to conclude these different brief ideas, COVID-19 pandemic is a transboundary crisis that challenges the resilience of individual organizations, states, and supranational entities. They also demonstrate failure in applying preparatory measures. COVID-19 pandemic records the existence of border. In the European Union controls, we have forgotten what is border. And the dynamic of border impact on early warnings, availability of resources, travel means, hotels, and challenge evacuation and repatriation of citizens. National thinking and stigmatization of foreigners emerge for this different area, and bordering, debordering, rebordering were coming back to the debates in the political agenda. COVID-19 pandemic also reveals the uniqueness of borderland. So these specificity areas transform from joint developments to barriers and controls. The border, this place was the space of friction of the national policy, of the difference between national policies. And bordering for health prevention, but mainly for preventing political tensions. National thinking, but solidarity between health systems. So COVID-19 pandemic challenged the resilience engineering community. First, we still are in a crisis. And it questioned how can we anticipate how the crisis will escalate. It also challenged the natures of system capacity to respond to transboundary crises with networks, polycentric networks with the huge difference between culture and law systems. It challenged how to monitor systems' readiness to respond to transboundary crises, and also questions how to learn from this crisis. So thank you very much. And I will give back the end to Simon.
Thank you very much, Eric. Very interesting analysis of borders and an aspect of borders that I certainly hadn't considered to this point. What we'll do is we will actually take questions at the end once all the speakers have finished, in case there are questions that you would like each speaker to address. So what I'll do now is just hand straight over to Marcos to present his piece, and then we will take questions right at the end.
Okay, thank you, Simon. Good morning, everybody. Good afternoon or good evening. I was introduced as a person from Brazil, which I actually am, but I'm from the Federal University of Rio de Janeiro. I used to be, but now I'm working in San Sebastian, Spain, for the University of Navarra, the Tecnum. And so I spent most of my career in Brazil, but I retired and now I'm working here. So what I'm going to talk about, don't know. Actually, I'm going to talk about don't knows that we've been hearing from the news since the beginning of COVID-19. There's a lot of don't knows. Yeah, you can mention some here that people say, when this is going to end? I don't know. We don't know. Okay, that's the most repeated sentence by scientists, government officials, and the media since the beginning of the COVID-19. Yes, the COVID-19 is a new virus, quite different from what we've faced before and faced in the past, but uncertainty and lack of knowledge, so it's expected, right? I'm not a medical doctor. I'm not a pandemic researcher. I'm a data scientist, currently working in pandemics. So from my point of view, from my data viewpoint, the don't know part of the answers demonstrates that you haven't been prepared for such a situation. Not prepared as a medical or pandemic research in the terms of infectologists and so on. I'm talking about the data providers are not really prepared for this crisis. So that's why in my title I put that's an information crisis. The COVID part of it, it's an information crisis. Of course, there's the medical aspects, that the infection aspect, but we're not really to prepare to provide the evidence-based answers to these questions. The evidence-based answers usually guide decisions. And we haven't seen decisions in the last 4 months that does not really comply with the evidence-based kind of information. We have old lessons from the past. We have some pandemics in the past, but it looks like that we have learned to deal with the pandemics from the medical aspects, but not from the data aspects or information aspects. So this talk is not about the cure of coronavirus. It's about the data, metadata, and information, and how misleading of the treatment of data affects the understanding of the coronavirus spreading, and consequently affecting the decisions around it. We claim that the brute force instruments, such as the general isolation, social isolation, was adopted due to the lack of appropriate data to act differently. So it works, it certainly works to flatten the curve. There's no doubt about that. I'm not questioning this. What I'm questioning is that it was adopted as a general measure. And as a general measure, it also has general side effects. So the side effects could perhaps, if you have more information, could be work differently. Different for depending of the type of the population, depend of the density of the population, but we need information in order to deal with that. So We've seen in recent past several types of reactions. I will select 3 of them and give you some examples. The first is a reaction from the governments and the authorities that base their decision on information, mostly coming from testing. And it exemplifies the policies adopted by South Korea and Germany and some other countries like Singapore. The second attitude we've been witnessed is the wishful thinking. That assumed that without support information, that the impact was not that serious. So don't need to take really serious measures here to prevent that. So that attitude delayed the response and the reaction. The reaction came very late and forcing more drastic attitudes, such as the total social isolation and lockdowns. I think Italy and Spain, unfortunately, were examples of this initial reaction. They changed now, but at the beginning, it looks like they are not believing the effects and how serious was the crisis. The third, and unfortunately I have to sit my own country in that, is the irresponsible denial of the situation, despite of the previous evidences from other countries. Measures were delayed, mostly justified by the effects on the economy, but now they are taking more serious measures, not so serious in case of Brazil, but they are taking more drastic measures, but they took too long to take those measures. So they are in a bad situation, and still there is the pressure from the economy to relax on these social isolation measures. So we can divide the analysis in 3 parts. The first part I'd like to mention is the immediate past. Immediate past means from 2000. We have several crises in these last 20 years. You have the COVID, SARS, you have the MERS, you have the H1N1, you have the Ebola, you have the dengue. So just to mention a few of these, all those kind of diseases that affect the people. Yet, right, this experience that should have provided some evidence on how to deal with the pandemics, they didn't work very well for this purpose. It happens that at the end, those pandemics were very kind of light. They killed not many people. They were blocked in some way. So I think because of that, we relaxed. We relaxed because, well, that's a kind of thing that we can control from the beginning. And it happens that way, but for example, we have in the SARS-CoV, we have 8,000 cases, 8,400 cases. But you have a fatality rate of 9.6%. So it was a serious disease, but because of the 8,000 cases, we didn't take it very seriously. The same happens with the MERS, the same happens with some other minor diseases. It's different from the case of the Zika that affect many people, but there's no such a fatality rate, a high fatality rate. So the lessons we learned from these events had the opposite effect, that we don't need to be very prepared for those things. We can control that. We can deal with that on the fly. And for COVID-19, it's not happening this way. We are not able to deal with that on the fly. We lack lots of information that is putting the crisis, is getting the crisis much worse than they could be if you have enough information. Okay, so this is about the immediate past. What about the present? Okay, the general public, not talking about the scientists, not the authorities, but the general public has a great deal of uncertainty. And with uncertainty comes fear, and fear that influences that people's decision, right? So questions such, what are the chances of getting infected by COVID-19? if a person develops the symptoms of the disease and has to go to the hospital, what are his or her chances of surviving? Don't know. After the quarantine, will it be safer to go to the streets? I don't know. I won't. How safer is that? We don't know. People say that, well, okay, now it's safe. Is that because you are more aware of the risks? Or is that because you take the precaution, like using masks? I don't know. I mean, I don't think anything has changed exactly on the COVID-19 in terms of treatment. So the only thing is that you can be sure that you get a place at the hospital, perhaps. But apart from that, not much more, right? So to flatten the curve that people say that is very important, the authorities say it's very important, that I agree with that, because we have not enough capacity to deal with the disease at the same time. With the attitude correct at that time, and it has been corrected in some other countries that are still in the beginning. But after that, it looks like in some countries like Spain and even Italy, that the crisis has passed. What changed that? I mean, we still hear the second most sentence that we hear in the media, that is stay at home. That's the second one. First is don't know, second is stay at home. You stay at home, but okay, but why? I mean, what changed now that that has phase 1, phase 2, that allows me to go to the streets, to go socialize with the people, with of course with the measures that you have to take. I think there is still a lot of absence of accurate information to really guide us to the attitude that you can adopt from now on. So still we will have the brute force, right? That's the social isolation. Or we have wishful thinking that say, okay, everybody will get infected anyway. So I don't know, the soon you get it, the sooner you get out of it, perhaps. But we don't have the necessary data to justify this kind of decision. So following up, I mean, to sum up, I think we are not prepared to deal with the pandemics, mostly because we don't have the knowledge or information required and have not prepared as data scientists for it. We are not prepared to provide data on the flight, provide information on the flight, sorry. We're simply not prepared for doing that. We should have been prepared for doing that. That's kind of give you some resilience in terms of information to the crisis. So the third part is the immediate future. Okay, so in the middle of still in the middle of the crisis. So how long does it take to finish the crisis, and what's going to happen afterwards? We're not really sure about that. Are we going to have a kind of normal life? I don't believe, but it's a question of feeling. I don't know. I really don't know. What kind of job losses we're going to have to face? People talk about millions. I don't know. We will come back to the normality that we have before. I don't think so, but I don't really know what the percentage of that. So there are many questions without a clear answer, mostly because we again lack the sufficient information to answer those questions. From the point of view of a person, what is the best kind of situation? The best would be that I got the COVID-19, I got infected by this, reacted, and produced antibodies. Now I'm safe, that people say. For how long, I don't really know, and people don't yet know. But that's the best situation, because then you're kind of protected against getting the coronavirus again, or the infection again. But still, many people don't know. Some of the testings on antibodies has shown that you have about 5% of 5% of the population only have antibodies. What about the 95%? Okay, to sum up and finish my talk here, whatever happened with society, one thing that we hope that we change the attitudes is the attitude of government towards the science. Not only medical science, not only pandemics, prepare for the pandemics from the point of view of infection or the virus, but especially, in my opinion, to be prepared to deal with the lack of information, to deal with the uncertainty of information, and to get information on the fly to respond and to support decisions, right? So preparation for climate change, for example, catastrophes, pandemics, and less than just words have the priority in the future. And maybe you want to be much to believe upon without this. That's the message I'm trying to pass to you. I think we have to prepare to capture, process, and provide information to decision makers in order for them to make decisions based on evidence, based on information, not just wishful thinking, not being pessimistic or realistic. Thank you very much. Thank you, Simon.
Thank you very much. Thank you. I think it's interesting that I present last, and I think it's appropriate I present last because my presentation starts with borders and information as a starting point. I am involved with a number of projects in healthcare, and all related to resilience. But when we heard that COVID-19 was on its way, we adjusted our approach in some of these projects to be a focus for resilience within healthcare. And it was very appropriate to shift our focus because of the significant change in the way healthcare people were going to need to work. And they were really having to change because of a number of things. One is the amount of information that they had to deal with as clinicians and as people organizing healthcare. So there was a massive amount of information coming from early outbreaks. So how the disease was spreading, how clinicians were responding to that, how hospital structures were changing, and so on and so forth. So there was a massive amount of information coming from early outbreaks, but there was also a real focus on sharing. So there was a real breakdown in borders at a digital level to ensure that this sharing was being learnt. So the challenge that that clinicians had was to try to pull this information apart, try to assimilate what is relevant to them, to really understand the impact in their particular circumstances, to adjust the way in which they work in order to respond in their particular environment. And what we found from discussing with many people within healthcare, both clinicians and managers and leaders, was that actually the professional bodies were providing information, but a lot of information was coming very quickly. Some of it was not keeping up with the change in practice on the ground. Some of it was contradictory. Some of it was in too much detail to really assimilate. And what was actually happening was that clinicians were sharing in informal networks on social media and so on about the ways in which they have adjusted their practice. So what I decided to do was to run some webinars to basically bring healthcare people together to actually assess what adaptations they are making, and and we really focused it in around a number of questions. And the first really important thing to do was to reflect on the fact that really clinicians and even people within the management and leadership of hospitals just do not have an awful lot of time to reflect. The situation is so frenetic, there's so much going on, there's a real focus on caring for patients, and the kinds of questions that we were asking may not be being asked by those that were really working in this environment. So the first thing we did was to really focus everyone's mind by giving them 2 minutes at the start of each call to really focus on these questions. So it really reflects what is happening. So we are acting according to the conditions that we've created in the past. So there is a general way of working which we are following according to conditions and processes and procedures and policies written previously. Then we're in the present, so the work is done aspect. So we are now actually dealing with the pandemic. We are changing the way in which we act in order to respond to the crisis, and we are doing it to do the best for our patients right now. And then there's the future. So what do we imagine healthcare might look like following this pandemic? So we wanted to really focus not only on responding to the crisis, but actually what should be retained beyond the end of the crisis. And so these were the kinds of things we wanted to reflect on, the participants to reflect on. Now, we ran 2 of these webinars, one in the UK, or at least based in the UK, but we had 132 participants from 11 countries that participated on it. The second call was based in the US, it was with the Mayo Clinic, one of the largest healthcare providers in the US. So this was very much, this was more US focused, so, but there were 205 participants on these calls. And what we wanted to do was bring these people together, not to use it as an academic exercise, but really to help people learn from one another at the time. So we very much focused on people sharing their adaptations on screen, in the chat box of the call. So we really focused, share your adaptations. What are you doing? And we did that around these 3 questions. So the first question was about the adaptation that the participant is doing right now. So how have you changed your practice that has made a beneficial difference to patients? And we really wanted people to focus on these particular aspects and actually spend some time doing that. And what was interesting is despite the fact that we had many clinicians on the calls, on both calls, actually what we found is that we had a huge amount of adaptations that came around team and organizational level. And actually the largest individual category of adaptations related to staff well-being. So it was very much about how healthcare is changing to make sure that the well-being of staff is being protected. That's the physical, but also the mental well-being of staff. And that was common across both calls. There was a huge amount of adaptation related to psychological safety, psychological support, and really changing the way in which we were caring for one another within a healthcare setting. There was also a huge amount of focus on sharing positive. So what can we do to change our practice to share the positive as well as the negative? So a lot of work about collaborative work, about debriefs, about safety huddles and so on. But really focusing on the number of patients discharged to their home, as well as the obvious negative performance indicators that you could find. The other thing that was very interesting is one was the massive uptake in the use of virtual consultations for doctors, but actually some of the negatives of virtual consultations were shared. So actually don't just run to virtual consultations for everything all the time. There are some problems with virtual consultations, the lack of privacy for patients and so on and so forth. So there was a real focus on that, but also a focus on the benefit to staff when they are shielding or self-isolating at home, to use virtual tools to bring them into the team, to continue to allow them to add value and not just feel left out and left at home, but really bring them in and gain the benefit from their wisdom whilst at home. And there was also a huge amount in this question about the changes, the adaptations supporting change. So the change in management style, the flattening of hierarchy, the allowance of decision-making at a much lower level, and the change in governance structures to allow changes to be approved very quickly, not going through a committee, but actually decisions being made locally and being approved very quickly. So there was a huge amount of these supporting structures that were shared. So this is a very key way in which resilience was demonstrated. It's not just about clinical change and people taking risks. It's about the approval process adapting in order to allow it to happen. And also a focus on command and control being relevant where appropriate. We then asked a question related to the future. So with all of these adaptations that are being made, well, actually, what new possibilities do they offer? So how can they continue to use this going forward? And how can healthcare be improved long-term as a result of these adaptations? And again, there was a huge amount of organizational level changes. So there was a focus on these new networks that are built. So clearly people are adapting, they're taking new skills and so on. And so we should retain this idea of how do we build networks? How do we share skills? How do we become more flexible as a real critical thing to do taking forward? Obviously, virtual consultations, the acceptance of them when used appropriately will be very important going forward. Home working, again, very, very important, and we should embrace it going forward. The other thing that was focused on in this particular sector is a significant drop in incident reporting. So there wasn't as much incidents reported in this, but a huge increase in the amount of excellent reporting. So there were many examples of really good practice and patients really being appreciative of the work and reporting excellence as well. So that's a real focus. You know, how do we carry on doing that? How do we carry on supporting excellent reporting? And then finally, what we also wanted to do was to really reflect on what people can do differently right now. So this is not structural change. This is actually you as individuals. What can you do? And there were some really interesting things that people shared about how they can change their practice right now. Who really needs to see a patient? Asking that question all the time. So does it need to go from a receptionist to someone else? Actually, can we cut that down? So make ourselves more efficient and more focused. And actually, that's something that people said that they can do differently right now. And then very simple things like thinking before you're sending an email, thinking about who to send it to. Is it wasting people's time? And when it arrives in their inbox, how is it going to help them immediately? So really trying to cut through the hundreds of emails people are receiving to really being helpful. So that's some of the examples that we had related to what people can do differently. And it's clear that there were a number of negative aspects to adaptation that were shared. So how do we really understand this idea of when do we standardize and when do we allow adaptation? So how are we going to go through this transition of ultra adaptation through back to standardization? And how do we ensure that people know when to follow a procedure and when to adapt? And these things that were not solved in the webinars, but really the questions were posed. So that's sort of a very quick summary of what we did. We are running more of these webinars, so anyone that's interested, then please drop me an email. But the focus now is in one area. We're focusing down on staff wellbeing, so we're having a specific webinar related to staff wellbeing measures to share these adaptations, to really help people understand how they can focus on staff wellbeing and sharing the good practice. So that essentially is the end of my my slides to really focus people on actually how they can adapt their practice within a healthcare setting. So what I'd like to do is invite Marcos and Eric to unmute, and really what I'd like to do is just to offer the floor to the participants on this call to really offer some suggestions on and some questions on what you've thought of this and any ideas. Just picking up on one, there is one call for you, Eric. So can you see the chat box there?
Okay.
So I wonder if you would just ask the question and then repeat your response.
So I will maybe read the question so that everybody have the questions. It's from Jonard Gurley. How do you compare the border response mentality in the EU versus the US? And how those differences affect the resilience and impact of the crisis? The EU rapidly reinstated state borders, where the US has maintained free movement between states, believing that it's not possible to close these borders. Good question. I think it's connected to which values we will evaluate if one country, territory will be resilient or not. Or we will compare the resilience to COVID from one system to another. It's very difficult actually, because if we consider only the number of deaths, it will be one thing. If we consider the number of deaths, the number of new unemployment, number of companies will disappear. Maybe we will have totally different results, and that will justify or not some strategy. For the comparison, I would say what is surprising for the European Union is that in the response plan for a pandemic, it is said that European internal border should not be closed. That states have to be careful to not close the border in order to maintain activities, essential exchanges. And the reaction was totally the contrary. Each state was turned on itself and closed the border and tried to manage. And in France, for the freedom of movement, actually, we cannot do more than 100 kilometers. So in France, they arrived to limit our possibility of moving from 100 kilometers for our house. So we have this issue. that from the health point maybe is positive. The question will be after, with the economic vulnerability that we are creating, for the depth that we are creating in 2 years, 3 years, we will see if it was good or not strategy. So maybe this month we can evaluate from one point, but maybe in 1 year, in 2 years, in evaluating the different country recover and then starts feeling better, maybe we will have different other comparisons. So it's very difficult actually, as we are inside the crisis, to compare the two.
Thank you, Eric. Just picking up, there is another question here for me. Do you have any way to differentiate whether the change in incident reporting to excellent reporting is a change in clinical behavior versus patient behavior? It appears that during the pandemic, people are generally more appreciative of healthcare worker efforts when normally they would have complained. Have you looked at what we might be able to do to help patients adapt their behaviors rather than expect all of the change from providers? No, I think we haven't looked at this in detail yet. I think there is certainly one of the reflections was that there's a drop in incident reporting because, frankly, clinicians haven't got time to report incidents. So I think in a way you can't compare them. Often the excellent reporting is coming from patients, whereas incident reporting would be coming from clinicians. So I think the drop in incident reporting is not a reflection of the fact that there aren't incidents happening. I think it's more the fact that there aren't as many being reported. The excellent reporting, yes, I agree. People are just hugely appreciative of what's going on. In the UK, at 8 p.m. on a Thursday night, we all go outside and clap for our healthcare service. I'm sure there are similar things going on in other parts of the world. We are very appreciative of our healthcare workers. So I think my own personal opinion, and this is based on my own knowledge and rather than any research or any particular evidence, is that some of that will continue, some of that appreciation will continue, some of that acceptance of the difficult jobs that are conducted not only by healthcare people, but social care, within social care, within community care. I think a lot of that will continue beyond this. But I do think that what we need to do is we need to put in place the things to encourage people to give feedback, and that feedback, whether negative or positive, can be used to change practice. Yeah, I think it's one that we need to spend a bit more time looking at. There was also another question from Yvonne for me. What are you doing with the responses? What was the feedback from participants? Well, the first one, what are we doing with the responses? Well, we have done an analysis of the first call, which happened a few weeks ago, and that is available on the website. I'll drop a link. If you hang around after the end of the call, I'll drop a link in the chat. The second call only happened last week, so we are just analysing the responses of that at the moment. So we will continue to share them, to blog about them. I'm sure there'll be something in the Resilience Engineering Association newsletter. to try to pull this together and to share it as widely as possible. The feedback from participants was amazing. We had most people stayed for the entire call. The feedback at the end of the call was very positive. Many people wanting more of them and suggestions on what we might do, which is why we've started planning this staff wellbeing one, to focus down on one particular area, to give us more time in one particular area. So universal, really good feedback, and yeah, we're going to try to do as many as we can to try to help as best we can in what is a very difficult time for healthcare professionals. Can I ask our participants if there are any final questions before we wrap up? And I guess, okay, Philippe, a further question. Do you think that proceduralization in healthcare is supposed to increase, as in aviation, behind an accident after the crisis? That's a difficult one. I think what is clear is that healthcare leaders are being very open to a very very accepting way of practicing, so not proceduralizing in the crisis, and really allowing for adaptation without trying to proceduralize too much. But I think, as we know, there is always the reaction to that, which often leads to more proceduralization. Actually, I think one of the comments made on one of the webinars was that actually even the staff will appreciate more proceduralization, more false stability, because they're just tired, and actually following procedures and having a false sense of stability will actually give them some time to relax. So I think it's very tiring adapting continuously, and I think the leadership within healthcare is not necessarily ready for a massive shift towards this idea of adaptation. So I do think that proceduralization will increase, and yet there is also a huge amount of interest in how healthcare organizations be more resilient, and proceduralization is obviously is only one part of being more resilient. So I think it's one that we're going to have to watch as this crisis diminishes, and we're left with the aftermath to see how we deal with this, and to see how much proceduralization there is. Can I ask if there are any final questions before we wrap up? Okay, well, I think just finally, thank you very much to Eric and to Marcos for your time this afternoon, and your insightful view into two very different areas of resilience in this crisis. In a way, I had a much easier job focusing on adaptation, because we know that people are adapting all the time. I think your focus on borders and on information was very insightful. So thank you very much for your time and your contribution to the Resilience Engineering Association.